Wolff-Parkinson-White syndrome is one of the most recognisable conduction abnormalities observed on an ECG. This condition arises when the heart's electrical system takes a shortcut, which can sometimes lead to significant rhythm disturbances. So, in this video, we're going to explore the inner workings of the heart, what to look for on the ECG, the connection between these two aspects, the prevalence of Wolff-Parkinson-White and its clinical significance. Wolff-Parkinson-White is relatively uncommon, affecting approximately 1 to 3 individuals per 1,000, which translates to about 0.1 to 0.3% of the population. It is slightly more prevalent in males, and in most cases is congenital, which means individuals are born with it rather than developing it later in life. Many people remain asymptomatic and discover the condition incidentally on a routine ECG, while others may experience palpitations or sudden tachycardic episodes. Although the risk of sudden cardiac death is low, it does exist, primarily in those who develop atrial fibrillation that rapidly conducts through the accessory pathway. Before delving into what goes wrong, let's briefly review how electrical conduction typically functions throughout the heart. So, we have an impulse originates in the SA node. It spreads through the atria and reaches the atrioventricular node, which will delay conduction briefly to allow the ventricles to fill before contraction. The impulse then travels down the bundle of His, through the left and right bundle branches and into that Purkinje system. This will lead to a coordinated ventricular contraction. So in Wolff-Parkinson-White, there's an additional electrical connection between the atria and the ventricles, known as an accessory pathway, or the bundle of Kent. This pathway bypasses that AV node, causing the ventricle to activate earlier than it is intended. This early activation is referred to as pre-excitation. When an impulse travels through both the normal AV nodal route and the accessory pathway, the two waves will converge inside the ventricles, resulting in a fused, slightly distorted QRS complex. Since the AV nodal delay is skipped, the PR interval becomes a lot shorter than normal. This accessory pathway can also create a re-entry circuit. If an impulse travels down one pathway and returns up the other, it can then loop indefinitely, leading to a rapid, regular tachycardia known as atrioventricular reentrant tachycardia, AVRT. There are two primary types of AVRT, orthodromic AVRT and antidromic AVRT. So orthodromic conducts down the AV node and returns via the accessory pathway. This results in a narrow complex tachycardia. So antidromic AVRT travels down the accessory pathway and back up the AV node, producing a wide complex tachycardia. In cases where patients develop atrial fibrillation, the accessory pathway can permit extremely rapid conduction to the ventricles, occasionally leading to ventricular fibrillation. The classic ECG findings for Wolff-Parkinson-White include 3 hallmark features: a short PR interval, a delta wave, a widened QRS complex. The PR interval is short, measuring less than 120 milliseconds as the impulse reaches the ventricles early by bypassing the AV node. The delta wave is a small, slurred upstroke at the beginning of the QRS. This will indicate early depolarization of the ventricular myocardium through that accessory pathway. This results in a gradual rise in the QRS, contrasting with the sharp vertical rise seen in normal conduction. The QRS complex is often widened beyond 120 milliseconds because the early depolarization merges with the normal His-Purkinje depolarization wave. Secondary ST segment and T wave changes may also appear discordant to the major QRS direction. These features can be intermittent. The accessory pathway may not always conduct, causing a patient to alternate between a normal and pre-excited ECG. When you connect the ECG findings back to that underlying physiology, it becomes a little bit clearer. That short PR interval indicates that AV node has been bypassed. The delta wave signifies early ventricular activation via that accessory pathway. The wide QRS reflects that fusion of normal and abnormal conduction pathways. This combination of a short PR interval, a delta wave, and that widened QRS defines pre-excitation. So now clinically, Wolff-Parkinson-White can manifest in various ways. Some individuals are completely asymptomatic. Others may experience palpitations, lightheadedness, or syncope from reentrant tachycardias. Tachycardia episodes can be triggered by exertion, caffeine, alcohol, or may just be completely spontaneous. In rare instances, rapid atrial fibrillation in a Wolff-Parkinson-White patient can lead to severe hemodynamic collapse or cardiac arrest, although this is uncommon. The long-term management approach is often curative. If symptoms are significant or arrhythmias are documented, radiofrequency ablation of that accessory pathway can effectively eliminate that abnormal tissue. For some, Wolff-Parkinson-White remains an incidental finding on an ECG that only requires documentation and follow-up. So in summary, Wolff-Parkinson-White syndrome is a conduction abnormality characterised by an extra electrical connection that enables the impulse to bypass that AV node into the ventricles. This will result into a pre-excitation of the ventricles, manifested as a short PR interval, a delta wave, and a slightly widened QRS complex on that ECG. The same pathway can give rise to reentrant circuits that lead to some tachyarrhythmias. Grasping how the ECG relates to the underlying physiology of our patient will aid in the swift recognition of Wolff-Parkinson-White, distinguishing it from other causes of wide or irregular rhythms. So thanks for watching. Please make sure you are subscribed to the channel so you get notified of all of our new videos we're going to be releasing over the coming weeks. And also hit the link in the description. It will take you to our website where we've got all sorts of emergency medicine, pre-hospital education and products.